Thanks, Christina. I think I'll hold it another minute. I've got 1:59, so we'll give it a minute, let everyone get on. Okay. Good afternoon, everyone. I've got 2 o'clock. We'll go ahead and call the Maryland Prescription Drug Affordability Board meeting for October 28th to order. Quorum being established with all board members present. Joe, thanks. I know you've got a tight schedule today. Hopefully we can get through this. First order of business is the approval of the September 10 minutes. Do I have a motion?
So moved.
Jerry, yes.
Joe moved, Jerry second.
Steve second.
Steve second, I'm sorry. Any discussion? All those in favor submitted as
Aye.
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 opposed? Great, thank you very much. Christina, is there anyone for public comment today?
We have received one written comment that was provided to the board and posted to the website. We also have one person registered to provide oral public comment today. This person will have 1 minute and 30 seconds to speak. Once I call on you, please state your name, the organization, agency, employer, or other entity with which you are affiliated, if any, or whether you're a consumer, and the agenda item that you would like to address, and then you can start your comment. Lynn Howard, are you here? Lynn Howard? Dan, it doesn't look like the public commenter is online at this point.
Okay. If you get contact from them and they want to submit written, they can do that. And we'll
Okay.
add it to the record and send everyone a copy.
Okay, thank you.
With that, I'll turn it over. Item number 4, Andy, upper payment limit action plan update.
Great, thank you, Mr. Chair. So we very much thank the board for getting this meeting onto the calendar. There were scenarios where this could have been a substantive meeting, but just based on schedules and different issues, this is primarily going to be updates on each of the different issues listed on the agenda. So I will go through this, and there are a few key issues the staff would like board feedback on, so I'll provide those as part of the update. So as folks may know, we had the opportunity to present to the Legislative Policy Committee last Tuesday. And for your reference, the Legislative Policy Committee needs to approve our upper payment limit action plan to allow us to implement the process that we've created through that upper payment limit action plan. The committee received 22 comments and ultimately did approve the action plan with a vote of 15 to 5. So very excited, very much thank the Legislative Policy Committee and their leadership for their time and insightful feedback and comments. We also appreciate the comment letters that were submitted to the Legislative Policy Committee that was reviewed by staff and also shared with the board for their reference. The next step is to publish draft regulations that will implement the policy review process outlined in the upper payment limit action plan. So that's ultimately the next step for the board and the Legislative Policy Committee. Staff has published a draft of the regulations on the website today. They were not available in time for them to be meeting materials, so that will be the topic of a subsequent board meeting. But the Legislative Policy Committee is meeting on November 4th. So the draft regulations have been published. We're asking for public comment through Friday, November 8th. We do invite all folks that are attending this meeting to provide public comment, and then also this legislative the stakeholder council will have the opportunity to weigh in on the draft regulations and provide comment as well. So that's probably going to be the largest portion of their meeting next week. We'll be posting the presentation and presenting to them on Monday. So those are the key next steps. And again, we're just trying to provide as much flexibility for the board moving forward on how you want to move forward with this process. The last scheduled board meeting is on November 25th, 2024. And one thing that we wanted to bring before the board for public input or for some general discussion is our upper payment limit action plan refers to a monitoring plan and requires us to publish a monitoring plan on how we're going to monitor for the work that we're doing around upper payment limits. And we did want some guidance from the board in the meeting today on how to move forward with that monitoring plan. The two questions we have is what we should be monitoring for. So are we monitoring just for shortages and access issues or unintended consequences? Or do we also want to monitor for compliance? Are the folks that we're regulating, are they doing the work as we expect them to do the work? So that's one question we have for the board. And then also what we should be doing as part of the monitoring plan. The staff is proposing a passive monitoring process that allows folks to notify us if they are having trouble accessing a drug or if there's a shortage. So that can be through a number of different mechanisms, whether it be emails or calls or anything like that. We'll be keeping a database of reported shortages in the state. But then also we hope to do some active monitoring. So there's a few surveys that currently already happen in the state to pharmacies. So we plan on trying to see if we can try to add questions around shortages to some of the existing surveys that pharmacies are already providing. So we do plan to do kind of, again, this active and passive monitoring. But I think as we put this plan together, we're interested in any ideas or feedback that the board may have as we get that process started. So board members are welcome to provide any insights now, or you can provide written feedback to staff at another point.
So this is Jerry Anderson. I think there's two areas that we need to focus on. One is the whole issue of shortages. And then I think the state does have data and the pharmacists do have data on this. So I think we can look at that. We also obviously know that the Food and Drug Administration has data on this. So we can also take a look at data they have for national shortages, not just Maryland shortages. I think it's very likely that anything that's a national shortage will also show up in Maryland, but I think it's relatively unlikely that anything will be just a shortage in Maryland. But I think we need to monitor that, especially if we set some upper payment limits in the future, whether or not there is access to that. So I think that's one side. On the other side is the whole affordability side. And I think we have a whole set of data on affordability, but I think it's also really important for the public to tell us which drugs are they having trouble affording. And so I think some kind of surveys or some type of outreach effort is very important for us to know which are the drugs that people are having the greatest difficulty accessing.
Hey, Andy, is there a monitoring program at the federal level now with CMS?
There's the federal FDA shortage list that has a pretty robust process for how I think it's manufacturers report the shortages and then they maintain a database. We think we may be able to provide or keep that a comparable database at the state level. So we are kind of looking closely at that process and seeing if there's anything we can do to replicate it at the state level. But yes, there is a pretty robust shortage process for the FDA.
What I think you got to know, Van, is that the FDA list and then the pharmacists associations have their own list there and typically are slightly larger than what the FDA says, but not always, and slightly different. So I think we got to monitor both of those. And then the question is, do we have to monitor something that's specific to Maryland? And there, I think we can look with, the pharmacist associations in Maryland to see whether or not they can identify any specific shortages.
Is there a way to filter just for Maryland, um, Maryland pharmacies or Maryland outlets?
Not at the FDA level as far as I am aware of.
I think that's correct. I think we would create our own separate list for Maryland, but we can certainly look into that. And I think it was a good point from Dr. Anderson that a lot of hospitals now have their own shortage list, mainly around like if they need to make therapeutic interchanges if the drugs are unavailable. So we can look to that as a resource for shortages as well. But thanks.
Well, and also, aren't some of the national associations, i.e. cancer, oncology, aren't they following it pretty closely for their members as well?
Yes, I think that's right. So we can certainly look to those as resources.
And I think MedChi could be another source for this, because the doctors will know whether or not they're having trouble having their patients fill prescriptions. So I think there is a number of national and local sources that we can use.
Yeah, we are looking into that.
Great.
Andy, can
Thank
I
you.
ask, like at a high level, are we thinking about like monitoring like pre and post, a specific thing we do, and sort of like would we be looking, in the entire state? Would we be only looking at plans where we have some regulatory authority? And like, how do we think about like larger national trends going on when we're trying to make some of those assessments?
That's a great question. And I don't think we necessarily have an answer if you have ideas or guidance that you wanted to provide. And I almost put those in two slightly different buckets. The monitoring, I think, is supposed to be kind of a real-time, thing that we would want to take action on, where I think there is almost a separate evaluation process that we should do to understand both the potential, like, hopefully the positive impacts. So the savings and things like that. As well. So, I think we can include that in the monitoring plan, but I think we do intend to do some level of evaluation trying to understand the impacts of the policies.
Dr.
long-term.
York, under the statute, the board's authority is to monitor the availability of prescription drug products for which it sets an upper payment limit, and then to take action if there is a shortage of that product in the state.
Great, thank you.
That's helpful.
Okay.
I
think we have enough. Sorry, Mr. Chair, go ahead.
No, I was going to say, I think that kind of narrows it down a lot.
Yeah, this helps us. So we'll try to put this into a draft document that would be available for review by the board. So, okay. The last thing we wanted to flag, just as we do request, or as we look for public comment, is there are two new sections. Well, there's one section on the reconsideration procedure. And this is something that we are very interested in getting public feedback on. It's a complicated procedure that we'll be walking through the stakeholder council through, but we welcome folks' input and feedback on if, how, and when the reconsideration should happen. And then also the hearing procedures. Just wanted to flag that we are adding a new set of hearing procedures that allow for public hearings, allowing for public input. So I'm interested in the feedback on that process as well. So that's our update on the upper payment limit action plan. And again, we're very excited about the milestone that we hit with the Legislative Policy Committee and look forward to working with the board to continue to move the work forward.
Okay. All right. You want to move on to number 5, cost review study?
Yeah. So we'd love to provide an update on the cost review study process. So a few items to flag. First, we wanted to notify the board and the public that we're going to be opening public comments for the drugs that went through the RFI process. And we are going to be prioritizing public comments around the patient experience and clinician input. So the drugs automatically get a 60-day comment period when they're posted to the website. And we did receive public comments that were due on July 22nd of 2024. We received, it looks like 7 comments. But I think we do want to make sure that the patient community has ample opportunities to provide their experience and input. So we're going to be opening it up for another 2-week comment period, exclusively for written comments, as that's what our regulations are set up to do. Anyone can respond to this public comment, but again, we are prioritizing patient groups and clinician groups, and we'll be doing direct outreach to different stakeholders to see if we can get extra comments in that space. So did want to notify the board and the public that's going to be happening. The request for public comments or the request for comments is already posted on our website, and we're setting a response date by Friday, November 8th. So that is going to be the same date as the UPL regulatory comments are due as. The next update we wanted to provide is that, as you may remember, you approved the update to the cost review regulations to allow for the preliminary determination step. We wanted to notify you that it looks like those regulations, as part of the normal notice and comment process, will be posted in the November 1st register. And the comments for that 30-day comment period will be due on December 2nd. So we do encourage folks to provide comments on those cost review regulations through that process. And we also requested emergency status for those regulations, again, to account for the potential to incorporate our policy review process. So we wanted to make sure that there's this preliminary decision or determination in the cost review process. Right now, those regulations or that request is still under review by AELR, so we don't have an update on that. And at this point, those regulations are not yet in effect. So those are the general updates that we wanted to provide. The last thing we wanted to notify you on is that we did receive our RFIs. A number of folks responded to RFIs, and we're very happy with what was submitted. So we appreciate all of our partners submitting that information for the RFI process. Let's see. So those are the general updates that we have for everyone. The one thing we were hoping to get board input on is some of the data elements that we're working through that kind of have a broader definition. So we're working through developing the dossier that's ultimately going to be the document that we provide to the board for you to make your affordability determination. And there were 3 elements that we were hoping to get board guidance on as we pull the final document together. One is the disease burden, and we'll open up each of these for comment in just a second. But the disease burden is the disease burden of the condition that's treated by the prescription drug product. We're interested in feedback and guidance on the impact of patient access. So that's the estimated impact on patient access resulting from the cost of prescription drug products relative to insurance benefit design. And then the last one that has some kind of broad or kind of opportunities for interpretation is the analysis of prescription drug products, lifecycle management, patent management, and regulatory exclusivities and product hopping. So we wanted to just open those 3 elements up for comment from the board, just so we make sure that what we're providing to you is what you're looking for the purposes of making a determination on if a drug causes affordability challenges. So with that, I may open it up to the board, and we can also bring this into a larger conversation of just in terms of what we're going to be providing to you through the dossier and what's going to be available to the board as part of that process.
Andy, this is Barry. Could you, with the very first element, review that again? This is the disease burden topic. Oh, it looks like you're muted.
Yep, our regulations allow the dossier to discuss the disease burden of the condition that is treated by the prescription drug product. So for the first 4, just the primary indication is going to be for diabetes. So what information is most useful to the board in terms of disease burden that can help you decide if it's causing an affordability challenge or not?
Okay, great. Thank you for that. I might have a clarification question first. So based on our regulations, are we limited in the perspective we can take on answering that question? Is it a disease burden from a patient and family perspective in addition to a healthcare system perspective. And then that certainly feeds into the cost piece, but I wanted to begin with the disease burden side.
I defer to council, but I don't think there is a limitation at this point. So that's why we want to make sure that we're
Okay.
making the
Because if we're
data.
not,
Right.
yes, I was asking because if we aren't expressly limited to the healthcare system, then I think it is a responsibility of the board then to make sure that we're including the patient and caregiver and family perspective as far as that disease burden goes. That will then broaden the scope of data elements that we would be collecting, as well as the types of data that we would be collecting. So in that case, I think it'd be important for us to make sure that the data sets, whether it's administrative existing data or survey data, that we are really prioritizing both perspectives, healthcare system, as well as patient and family burden when it comes to understanding disease burden. And there are data sets available. We just have to be intentional, I would say, in terms of the data sets we use or the sources of data that we are commissioning.
Great, thank you.
So I agree with Barry on that particular issue. I'm actually a little bit concerned about just relying on the APCD data for this for a couple of reasons. One is some people, because they don't have insurance and for other reasons, are just not treated. So they won't be showing up in the APCD. Second of all, there's not always a strong relationship between a specific disease and a specific drug. So a lot of diseases are used by multiple drugs. So I think that's a challenge as well. So I think it's an important set of information, but I think what Mary suggests is an important addition, or really probably for me, the more important component of it, as opposed to looking at just the APCD for disease burden information.
This is your attorney who's going to try and answer your question, Barry, but I wanted to make sure I understood the issue that you were framing. And is it that the question of disease burden is reviewed through the prism of the disease burden to the overall health system? Is that what your question was?
Yes. So with disease burden, my question is, are we looking strictly at disease burden as viewed from a healthcare system perspective, which won't be the same typically as when you consider disease burden from an individual or family perspective, where there may be considering aspects that are sometimes invisible to the healthcare system, or maybe visible but not germane, right, to their operations and costs, if you will. So there are survey sources of information that can allow us to understand disease burden more generally. But I wanted to first make sure that our regulations, if they did limit the perspective, that we were aware of that. So that was my question.
And I'm going to take that under advisement and look at it more closely under the statute. I think to the extent there are constraints, there are statutory constraints, but I will get back to you after taking a closer look at it.
I think that would be important for us to be clear on. And thanks, Michelle, for looking into that further, because that then frames out everything else that we do, at least for this particular topic in terms of data sources. If we need to solicit additional input, work with patient groups, all of that I think would come after we have a better understanding of the perspective we're to take.
I just have one element that I probably should have started with. Our regulations do have a definition for disease burden. That means the impact of the health condition measured by financial costs, mortality, morbidity, severity, and epidemiological indicators. But I don't think that necessarily precludes some of the analysis that Dr. Nook was mentioning.
No, yeah, that's helpful. And any of those we can consider from either of these perspectives.
Yep.
So when I think of the financial piece, there are going to be different lenses on that depending on what perspective we take or how broad we are permitted to be. But that is helpful to think about the scope. Thanks, Andy.
So Barry has raised an important point here of is there additional information that we would like to have? So I think, you know, what Andy and Krishna and Zaid and the entire staff have done is just done an amazing job of collecting data to help us select the first 6 drugs for our cost review. So very much applaud them. Now, as we sort of move forward, and look at the 6 drugs and trying to figure out if any of them are appropriate for UPLs or any of them are appropriate for other approaches. The question is, do we need additional data? And I think what we've seen is, you know, I've been working with the staff to try to collect and identify additional data, but I think it is important both for the public and for the board and for the stakeholder council to tell us what additional information would be very important to try to figure out what we need as we move forward. I sort of recognize that industry has given us some data confidentially, and I'm looking forward to seeing this data. I also sort of recognize that some of the data is a little older than I would like it to be, but you know, I think we can move forward with the data that we have in terms of the age, but I think it's really just important to say as we move forward, are there additional data elements that we should be collecting? And, you know, for right now, for me, I'm fairly comfortable with what we have, but I don't know that all the other board members are as comfortable as I am.
Yeah, I want to add to what Jerry is talking about. You know, additional data that would be very, very helpful is the amounts of rebates that are going on back and forth between insurance companies, PBMs, and manufacturers, because that very much figures into the cost to the state and cost to the patients. And especially for the 6 drugs that we've picked, but eventually to other drugs that we may be interested in working on upper price limits and controls. So those kinds of information would be most helpful. And I understand that it's probably very problematic and you know, private information, and you know, part of our regulations is such that we will keep the information completely private, and we won't be releasing it out to the public. But I think in our deliberations, that would certainly be very helpful.
Let me ask a question to Jerry and Stephen. Are you talking about data specific to our charge into Maryland, or are you talking about generic data around the country?
I'm talking about our charge specifically, you know. So we have gotten a lot of data as we selected the 6 drugs. I just want to make sure that we don't want additional data to try to figure out, you know, whether or not we should set a UPL on them and what the UPL should be, et cetera.
Well, can you maybe, just to flesh this out, can you give us some more, like what exactly, I mean, are you looking for something outside of state employees and retirees? Are you looking for general insurance costs with a Blue Cross Blue Shield or an Aetna or somebody? Or I'm just trying to understand exactly what you're looking for.
And
I think,
go ahead. I may have just an initial response to both of these comments as well as we start the discussion. So right now we're limited to reviewing the factors that are articulated in your regulations, and staff feels like we were able to collect the relevant data for those indications. So anything that beyond additional data sources or different factors are things you would have to address in your regulations, but staff is very confident that we were able to address the different factors that the board articulated in the regulations. To Dr. Rockhauer's point, some of the information that he was requesting came in through the request for information. So that, to Dr. Rockhauer's point, is generally confidential and proprietary information, but we did get some pretty substantive responses from our colleagues in the industry.
No, I'm very comfortable that we have everything that's in the regulations, Van. I'm just wondering, you know, sometimes when we start thinking about stuff, we'd say, gosh, I'd like to know this, or I'd like to know that. And so I think it's important for us to have a discussion as we think about it, whether or not there's additional information that we would like to see. Again, I'm comfortable that we have the data, but, Barry, for example, raised an important point about, how do we collect data if we need to about burden of disease in terms of the impact on individual patients. So that's a kind of an example of something that I'm thinking, outside of the box that we might want to be thinking about collecting. But again, I'm comfortable that, the staff has followed the regulations very carefully and, has given us the data that is required.
Yeah, and I don't want anybody to think, I'm not questioning the questions. I'm just trying myself to better understand exactly what you're looking for, because there's not a lot of specifics. I mean, if you could give me some examples, that would at least help me. I mean, I understand what a Barry was talking about, but I'm just talking about sources within, right, Maryland and where we are from a regulatory standpoint. I mean, if we have to expand, we have to expand. And I'm not saying I'm opposed to that at all, but I was just trying to get a feel for, are there other things out there that you feel that is available now that we didn't get? I guess that's my question.
So an example would be the CMS negotiated price for 2 of the 6 drugs on our list. For example, I mean, that became available recently. And so, we could use that in our discussions, for example. That would be one example of that. I'd like the data on cost and utilization from state Medicaid and state employees, and make it as current as possible. I mean, we have data, but, getting it as current as possible would be desirable. So I've worked very closely with the staff and I'm very comfortable with what we have, but I just want to make sure that other board members have had the same opportunity.
Yeah, and
Okay.
I would say that this cost review process for me is an opportunity to really understand and feel like we've done an appropriate 360, if you will, on the issue of affordability for each of the 6, for each of the drugs that's on the list. And that may require going back to understand what is our remit. And that's where my question came in around perspective. Because if we got to the list based on available data, that may not be the complete picture if we're trying to understand disease burden, as one example, from a perspective where the data did not cover that. And so APCD does not represent a patient and family perspective, and that's typical of administrative data. But yet, it's for us to confirm if that perspective is something that we can include. Because if it is, I think it's important for us to include that. And so, Van, you asked about what does that mean for the cost calculation or disease burden calculation. We oftentimes think in terms of direct costs when we think about the costs that healthcare systems care about. And from a patient perspective, that's out-of-pocket costs, and we have typically good information about that. But there are other costs that patients and families shoulder that are completely outside of the healthcare system, related to transportation, family, any other costs that they incur that allow them to seek healthcare services. Those would be completely invisible to us, as would costs by the uninsured. I think Jerry mentioned that. So I just want to be sure that as we're doing the cost review, we take a step back and make sure that we're clear on the perspectives we can include, and that those feed right into the data sources and then feed right into the asks that we would have of the community. Just a chance to kind of step through that process.
Okay, thank you.
I just have one response to that. One, thank you for this input. I think this is really great. And I think it aligns with a lot of the public comments that we've received, and then also what the Legislative Policy Committee received as part of their hearing. And right now, the best tool that we have to collect a lot of that information is the public comment process. So we will make sure that we're doing direct outreach to the different patient groups that are affected. And if there's a way we can try to get patients in touch with us, we will certainly do so. So we'll do everything we can to make sure that that information is represented. And we think we currently have a process to do that now. So thank you for that feedback. Just as a reminder to folks listening that we have a public comment process that's open until November 8th, specifically seeking input on a lot of the issues that the board members have discussed right now.
Andy, if that's all on cost review study, I don't know if anybody, could you go back a minute to the upper payment limit action plan update? And in regards to the regs, did you give a timeline to the board as to where we are in the process and what the timeline is going forward?
Yeah, so before the board can do the work outlined in the upper payment limit action plan, we do need to put the process into place through regulations. We are working on a schedule to allow the board as much flexibility as you would like on this space. So we are expecting so we posted drafts of the regulations. We're asking for public comments on the draft of those regulations by November 8th. We do expect that that can allow the board to take action in your last scheduled board meeting of the year, though the board, that's completely an option for the board. The board doesn't necessarily need to take any action at that point. We just wanted to make sure that we've done all the work that we can for the board to take that action. So ultimately, I think we'll be providing those public comments to you. We'll have a final version of the regulations responding to those public comments available for the board, but the board may say, we need more time or more, more input before the board takes action.
But I do
Not sure if that responds.
something about December 1st, Andy. You also said December 1st date that I at least heard in the background.
Yeah, that is the date that public comments are due on our emergency regs that create that preliminary step. So that's just for the cost review. You'll remember that we changed our cost review process to allow us to put this policy review process in the middle. We had to basically create this extra step. So that is, those regs are going to be published on November 1st. The public comment will be due on December 2nd. The board can then take action within 12 days, and we can send this to you as a separate timeline just for your reference. If the board is going to be taking action on those regs, they probably need to be approved as emergency regs, which we requested to AELR, and that's still under review. So we'll send you a full process, but for that step to happen in common rulemaking under the kind of standard schedule, the proposed regs will be published on November 1st. Comments are due December 2nd. The board would then need to approve final regulations, and then the final regulations go live after they're published. They have a publishing date, and then I think within 10 or 12 days they become effective. So we can provide that separately to the board.
But what does that limit us from doing on November 25th?
On November 25th, if they are not approved as emergency regulations, then they will not be in effect, and you will not be able to make a preliminary determination. It will be a final determination under our current regulations. If you take any action in the November 25th meeting on any cost reviews. An unrelated topic, I guess moderately related topic, is in your November 25th meeting, we plan to have enough the regulations available to the board to take action on if you would like. If you do decide to take action on them, the board would need to approve them. They would then be published in the register. There's a 30-day comment period, and then you need to publish the final version of the regulations. So two separate sets of regs. But
the activity on December 2nd, how does that relate to our ability to do something on November 25?
They're separate processes. So sorry. So you have these regulations that are going live. There are cost review regulations that are creating this preliminary determination. We've requested that they be approved as emergency regulations, and as soon as they are approved as emergency regulations, they're live and you can take action on them. So that's what if you're going to be doing anything with a cost review on November 25th. We need those emergency regulations to be approved. If not, then there is a separate sequence that it probably brings you into the beginning of 2025 before you would be able to take action under those new regulations. beginning of 2025.
If you could put this down in writing for us.
Absolutely.
I'd
Yes,
appreciate
I
it.
apologize for.
I follow
for,
it, but I don't completely follow what can be done when, etc.
Right, and I wasn't trying to create more confusion. I just didn't think Andy was clear when he went over the update with the regs on the action plan as to whether everyone understood that. So
Yeah.
do think, Andy, if maybe you and Michelle could get a timeline with the two sets of regs out there, align with the November 25th meeting before and after emergency, non-emergency would be probably helpful.
Great. We can do that.
Great. Sorry to bounce back up. Does anybody have any other questions or comments about either item 4 or 5? All right, good discussion. Hearing none. Andy, administrative update?
No major updates from us. We're about to send out the second notice for the FY25 fee assessment. So that process has been going on in the background. Huge thanks to the staff for their amazing work on that. And I think that's our main administrative update. And again, just thank the board for their time and putting this meeting on the calendar, and appreciate the opportunity to provide the updates today.
Can you, and I know sometimes you can and sometimes you can't, can you give a brief little update as far as the reverse auction with the state and where maybe we are in the process?
Yeah, I want to make sure I'm not speaking out of hand, but my understanding is that the contract has been awarded through the reverse auction process. So let me check what I can share, and I'll send that around as an update to the board, but has been awarded. I think there's a new pharmacy benefit for the state that has been allocated through that process.
Excellent. Good. Okay. Anything else?
Nothing else from staff.
Anything in Annapolis? Anything from Christina on Stakeholder Council?
Van, our Chair Mitchell, our next PDUS meeting will be next Monday, November 4th at 2:00 p.m. and that will be a virtual meeting. And as Andy mentioned, the bulk of that meeting will be discussing and obtaining feedback from the Stakeholder Council on the upper payment limit action regulations that were posted on the website today.
Great, and please pass along the board's thanks for the understanding with the co-chairs and the members that we hijacked their meeting day and had to move back a week. That was very nice of them. We appreciate it. Just a couple things for the board. As many of you know, we brought on Jim Johnson, who was a state employee for over 35 years, and I worked with at the State Health Department, one of the best budget people in the state of Maryland, running agencies for the last 40 years probably, and has been instrumental with the PDAB board and the beginning and the 5-year budgeting, along with working with Andy, bringing him up to speed with how things work in the state. We worked on a very small individual contract that dragged out for 4 or 5 years with Jim, and he was very judicious with his time and what he charged us, but he has given us the last invoice and we will be wrapping it up. And I just wanted to, he's not on, but I wanted to recognize Jim and his efforts to both Andy and the staff and the PDAB board for a lot of wisdom and a lot of hand-holding through the first couple years. Probably couldn't have gotten as far along as we have, and we probably wouldn't be in the financial steadfast that we are today. So again, I just wanted to thank Jim for all he did. And we've had some more involvement. Not sure, I think everybody knows, maybe, I don't know about Stephen, but after the MHCC involvement, you know, Jim and I wanted to partner with an agency, and we reached out to the Health Exchange because they were an independent agency, much like we wanted to be. And as you know, we have gotten that designation We are not under the Department of Health. We have our separate budget number and we are a separate entity within the state budget, which I feel is very important for this board going forward for autonomy. And I just want a little shout out to Michelle and MHBE's team. We have asked them to take over and help us with HR. As many of you know, HR and IT, and some of the things that we didn't want to go to the legislature and get pens for and put money in the budget for because we didn't think we needed full-time people in those positions once we got up and running. And I've recently had some interaction with some of their folks, and again, this is kind of outside the box. This is a way I think government should work. We're trying to run this as lean as we can. I know Jerry probably thinks we run it too lean, but I think that this is a good example of how partnerships within state government should work. And there are agencies that have bigger budgets than the smaller ones, and they've got expertise that maybe they can give a half a pen to or things like that. So long story short, it seems to be working. Andy, we're in our second full year, right? And they just did our closeout at the end of June 30, which they're working on with Andy and the state. So that these things don't come easy sometimes, and it might not be the best case scenario, but it certainly has helped us get to the first 5-year hurdle mark. So just wanted to recognize those couple things. Our next board meeting, as many of you know, is going to be in person in Annapolis, November 25th at 2 p.m. You'll get your parking notification from Christina or Andy or the Senate office. We'll start at 2 o'clock as normal. And with that, let me go around the horn. Is there any, Stephen, do you have anything?
I got nothing there right now.
Joe, you still up with us?
Yeah, I'm still here. No, nothing, nothing new for me.
You good? How about a Barry?
Nothing for me. Thank you.
Jerry?
So I'm very much looking forward to seeing everybody on the 25th. And, you know, I just think we should put an idea in there that we might need a December meeting. I don't want to call for one now, but we might need one depending on how much we were able to accomplish on November 25.
Understood. If not, I'll entertain a motion for adjournment.
So moved.
Second,
I second. This is a Barry.
Second?
thank you. We stand adjourned until November 25th. Everyone have a great day. Thank you.
Thank you.